Hello and good evening, and welcome to sixth session of our anatomy of abdomen. Now, see, today's topic is like heavyweight hernia because that word itself, heavyweight, is associated with hernia in so many ways. Say, topic is heavyweight. Yes, topic is heavyweight, right? Because you are learning it in anatomy, but say when it will come to surgery, again you will be learning this topic, right? And hernia is definitely associated with lifting of heavy weights, right? Lifting of heavy weights. So there are other reasons also, but this is also one of the reason. And when will it will come to the management, the treatment, the repair. So at that point, when we'll be talking about mesh, so there are like heavyweight mesh and lightweight mesh, right? Mesh. So that's why I thought of putting a word like heavyweight hernia because the word itself is associated in so many ways. And again, as I always say, right? It becomes a bit musical. All right. So let's start with our today's topic, and that is hernia. Very important topic. Now, you might feel by the end of our today's session that some of the details that they were beyond first year MBBS, but it's okay, right? You'll be able to understand everything crystal clear. One more important thing that at times you need to know those keywords about how to diagnose, and I'm very sure that you all are completely ready with those concepts, right? You won't find any difficulty. All right. So, welcome everyone, and let's start. So, hernia is this is a simple plain definition, right? That it is a protrusion of abdominal content through the area of weakness. I have highlighted those keywords. It is through the area of weakness. Now that area of weakness could be man-made or it could be natural or it may develop because of some abnormal movements, abnormal weightlifting, etc. Right? That's what we'll see. But the idea is area of weakness or defect, right, along the abdominal wall. Now in hernia, this is fine, this is definition. But we'll be putting a very special emphasis on that when you diagnose a hernia, you need to figure out that what are the contents of the hernia, because over here it is telling the protrusion of abdominal content. Now I know right now we have not yet talked about omentum, right? So just for the time being, consider it that omentum is like a covering, is like a covering to all those organs, right? We'll be discussing omentum, greater omentum, lesser omentum, all those peritoneal reflection in superb detail. But when it comes to say the protrusion means coming out, right? So this is like abdominal wall, and if the contents they are coming out, so that is called as protrusion, right? That is called as protrusion, coming out, right? I'll just write down so that to avoid any confusion, it is coming out. So when the things are coming out and it is telling that abdominal content. Now as I said, let's say this is like an abdominal content, right? Say for example stomach, right? Then there are all those intestinal loops, but these intestinal loops, all these, they are covered by peritoneum, right? So just consider that either only that covering is going into that hernia, or it is the even in the entire GIT is going, right? So that is all those loops, intestinal loops, they are also going. So that content is very important. So when we say when the GIT contents they are there, that is when the loops are there, intestinal loops are there, we'll call it enterocele, right? Enterocele. We'll actually look at the difference between this enterocele and when the contents are omentum only. So we call it omentocele, right? At this stage, right, that is this stage means that is when we complete our today's session, right? You should be able to diagnose it very systematically in a way that is inspection, palpation, percussion, and auscultation. These are the 4 stages of clinical examination. So not only like we'll be understanding the difference between enterocele and omentocele, but actually will understand the clinical rhythm, right? So that will make entire subject not only simple, but from this point onwards, whenever we'll be discussing anything in the abdomen, it will go into that order only. So that's why I wanted that some of the clinical aspect also, that is what we'll try to cover today. Okay. All right. So, right, this is the definition: protrusion or coming out of abdominal content through the area of weakness or defect along the abdominal wall. Okay, now abdominal wall, that means anterior as well as posterior, right? Though some are rare, but just because abdominal wall is not only anterior, it's complete circle, right? So at any point, wherever there is weakness, things can come out. Okay. Now let's see that in a classical hernia, right? In a classical hernia, say we'll learn the hernia this way. We'll see that when hernia occurs, what are the parts? Then we'll be learning about some of the terms or the terminology before diving deep into it. And yes, we'll also cover some of the anatomy again, a small portion. We'll spend about 5 minutes. The reason behind it is I got about 4 or 5 mails about some of the queries in anatomy. That's fine, no problems, right? But it was like said that if we can just brush up those things, definitely we'll do that, right? Okay, so that would be our action plan. Here it is. This is, just consider that it is a classical hernia, right? Classical hernia. This is how it happens. See, this is the content. Over here, content is a loop of intestine, right? So that's why this is enterocele, right? Enterocele. And this is the area that is the neck. That's what is called as the neck, right? That is what is called as the neck. So over here, entire thing is like a sack, is like a bag, right? So its neck is narrow. Neck is narrow, and that's the point of trouble, because when we'll be discussing the various types of hernia, we'll see that what if this neck strangulates, it becomes small. So many things can occur. That's what we'll see, right? Rest is all bulge. So this is the bulge, right? That's the bulge, and these are like coverings of hernia, right? These are the coverings. In fact, coverings, they are all those which are protruding out. Okay. All right. Now, see how dangerous it looks. This is like contents which have been herniated, right? Herniated into the scrotum, right? So contents, they are herniated. Now, what type of hernia? Well, we'll see. But it is like, this is how it looks like when the contents are herniated into the scrotum, right? So that's how it is. Now here is the CT scan, right? CT scan. What it really shows is, yes, this is the portion. See, we see that there is a mass. There is a mass, right? So that's the mass which we see into the scrotum. So that is the indication, because it is a soft tissue mass. Its consistency, if you see, right, it is similar to those intestinal loops. So that's what it is going. In fact, this is just one section. If there are multiple, so then it will be much easier. But just to show that you can have a look at these things even in the CT scan, right? Okay. A very quick anatomy, very quick. In fact, I'll explain you one very interesting hernia in this. So So question which was asked is that where exactly is the location of rectus sheath? Now see, these are the obliques, right? This external oblique, internal oblique, and transverse abdominis, correct? Those three muscles, as they come towards the medial side, right, they form that aponeurosis. And that aponeurosis, it really splits, and finally they find that they form linea alba, right? Linea alba was white, correct? This particular aponeurosis, right? It splits and it encloses this rectus abdominis. Rectus means straight, rectus abdominis, that is over there. Now this rectus abdominis has got its own sheath. That is what is called as the rectus sheath, correct? And this rectus sheath, all you need to remember is that this rectus sheath, all the way it starts from the top, it comes down, 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 but its posterior wall is deficient in its lower border, right? And that was the arcuate line which was forming. True, right? You got the idea? So that rectus sheath, right, that was forming that arcuate line, right? This is the end of the posterior wall of the rectus sheath. So I'll just write arcuate line, right? Now, it means, do you remember I used one statement? In fact, that was something which was asked in even in the mail also. The statement was that, see, this is posterior wall. It means on its let's change the color. On its outer side, now there is rectus abdominis. Now, because just underneath the last muscle was what? Transverse abdominis. Underneath the transverse abdominis, there is transversalis fascia, right? This one is transversalis fascia. So this means that when the posterior wall is deficient, rectus abdominis is in direct contact with the transversalis fascia or the fascia transversalis. You got the idea, right? Okay, so here it is. Why this is important? Because the fascia which is over here, it has got one very nice name. It is called as the Spigallion fascia, right? It is called as the Spigallion fascia. Now, actually, if you see, this is the potential place where there is weakness. When the muscles are there, to well, that area is pretty strong, right? But when there are two muscles, this is a junction between rectus abdominis and all those obliques. So this particular area is a weak area. And through this area, especially in the lower abdomen. Why in the lower abdomen? Because in the upper abdomen, right, there is posterior wall of rectus sheath. But in this area, right, there is no posterior wall. So that is where the abdominal contents, they can try to come out. If they are successful, they are called as, then we call this as Spigallion hernia, right? Spigallion hernia. So from where it is coming? It is coming from that anterior abdominal wall near semilunar line. What was semilunar line? Well, semilunar line was this. That is where the rectus abdominis, right? That was ending. So that was like semilunar line. So this is where, right? This area. In fact, it is this portion, this lower portion, this entire, right? That's where this posterior wall is deficient. So that is the area of our concern, right? So Spigallion hernia, common in lower abdominal wall, right? Where we saw that, and because posterior rectus sheath is deficient. Fair enough. Normally it never occurs, right? All these hernia, they occur because of weakness of muscles. That's the reason that when we'll be talking about the muscle weakness, right? In our today's session only, we'll be talking about that why your back muscles should be powerful, right? Right? Why your back muscle should be powerful. The way it is said that when you are running, right? When you are running, you are not running with your legs. In fact, you are running with your upper body. Sounds strange. When you go for the javelin throw, right? Javelin throw, that bhala, right? When you are going for javelin throw, you are not throwing with your hand. In fact, you are throwing that javelin with your lower limb, lower body. The reason is that you must have seen some person running like this, right? Running like this. Now that is tremendous wastage of energy. Your upper body should be rock steady, and it, in fact, only those hands, they should move with the momentum. So if your upper body is strong, so when you are running, right, upper body is properly balanced, it won't sway. If it is not swaying, so that means you are consuming less energy, you are conserving energy, and that way you'll be able to run for a long distance. Same thing is true for the javelin throw, that the thrust, that push, that comes when lower limb, it pushes the upper body, and that is what gives that final push or the thrust to throw the javelin, right? So that's why today, just after a few minutes, it will come. So at that point, I'll definitely mention that why your back should be so powerful, right? Okay, because there'll be concept of back muscles, core muscles, and so many things. So this was like Spigallion hernia, right? Now I know this is just too early. Straight away we talked about this rare hernia. Well, because it was coming into our path, right? As such, this Spigallion will come again. But at that point, as we are knowing it, we won't be talking much about it. Fair enough. Okay. So as I said, that we now go for few terminology. These are the terminologies which you must know. It's compulsory. And I know that you know this part very well. Midpoint of inguinal ligament and mid inguinal point, right? Mid inguinal point, that is from anterosuperior spine to pubic symphysis, the center point, right? Because that would be anterior iliac spine to pubic symphysis. It is like an imaginary line. You draw, you take at the center. This is the point which is so important because it is indicative of deep inguinal ring, and it is this deep inguinal ring from where the contents of the abdomen, they will try to come out. They'll try to pass through inguinal canal to superficial inguinal ring. From there they will try to enter into the scrotum, right? That is what is called as the indirect inguinal hernia. Okay, so yeah, so first word, right? This is uncomplicated, right? Now when you'll be writing any of the history, all these words are compulsory. When you describe or when you write the history of the patient, and if it is of any of the hernia, uncomplicated means this is reducible. What is reducible? Reducible means that the content, let's say the contents of abdomen, they are into the scrotum, but when you push, they'll silently go back. That is reducible, right? So it means there is no complication, there is no trouble, right? And you tell the patient to cuff, and always the face on the opposite side, right? If you are on this side, tell the patient that you move the face on the opposite side, tell him to cuff, and when he cuffs, you find, when you touch that area, you'll find the impulse, right? That is present, right? You find the impulse, you find the thrust. That is what is called as the uncomplicated. What it really indicates, because see, when the patient coughs, right, there is increase in intra-abdominal pressure. Increase in intra-abdominal pressure, that is getting transmitted to this herniated content, so that it is transmitted to your finger. You know that entire track is clean, and then you try to push it back, it goes back, so it means there is no obstruction. right? This takes us to the second word, and that is, as we use that word, that terminology, and that is obstructed, right? Obstructed. There is one very interesting name, or the alternate word is that it is what is called as the incarcerated, 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 right? This means that for some reason, right? Let's say, let's draw it. Say this is the hernia. That one is the neck. For some reason, this neck is tight, right? It becomes tight. So that now this content is not going back. It means this is irreducible. Irreducible, right? Inspiration, well, uh, not to complicate that matter, right? Whether it is with inspiration or not, right? Because we'll deviate from the topic completely. Because when we say inspiration, then we'll go for whether it is a thoracic or it is abdominal, and then when the diaphragm involvement, and we'll deviate from the topic completely, right? So that's why, yeah, as such it is related, but not here, not here. Okay, so this is irreducible. There is no cuff impulse. There is no cuff impulse. It means now that neck is narrow. It is not allowing the things to push, right? But, yeah, irreversible. Yeah, you can. But the ideal word is reducible, right? Ideal word is reducible. Reversible, well, we can use it, but these are the ideal term. Reducible means you can just push it back. You can reduce the size, right? That entire content, it can be reduced in size. While over here it is irreducible, but the vital part is that the blood supply is okay. Here the blood supply is okay. So it is not an medical emergency. Blood supply is okay, right? So can anything happen to blood supply? Well, here it is, right? Yeah, uncomplicated. Uh, well, as such, I tell you, uncomplicated, we can say that even, yeah. So you want to ask anything about uncomplicated? I'm not getting the question, right? Just let me know, right? Meantime, I continue and I'll take that point. Okay, the next one, which is called as the strangulated. The real word of strangulation means gala dabana, right? Yes, that is strangulation, right? Murder by strangulation, that is called as strangulated, right? When that neck is so much strangulated that even the blood supply is affected. Now this is bad. This is bad, right? Because in strangulation, this neck is bichar is so much, right? So that even the vessels, they have got no scope, right? They are now blocked. They are strangulated. So when the blood supply is affected, this is bad. Why this is bad? Because the portion which is beyond the neck, right, it can go into necrosis. This area, right, this area is not having any blood supply. Means whatever the blood it is there, it will remain there. It will consume its oxygen. Once the oxygen is consumed, now there is nothing, and then it can lead to necrosis, this one. And when that thing occurs, yes, all sorts of complication. So that's why this is a major emergency. It is a major emergency, right? We are just understanding the differences between all of them, right? Then we'll be talking about some of the other aspects. So remember this, blood supply is affected, correct? Incarcerated, okay. Incarcerated means obstructed, right? This is another name. As I said, this is just the another name. You can always write obstructed, right? Obstructed. But this incarcerated, in many of the books it will be used. Incarcerated, right? Incarcerated, strangulated, hernia. So that means it is obstructed as well as the blood supply is also affected. So this is like an emergency. Okay. This is just another name, right? Another name. In all those various types of hernias, so it will happen that there would be one common name and there would be another name which will be associated with some scientist, with some anatomist, someone who has discovered it. So it happens, right? And it would really happen. Okay, the fourth one, this is a procedure. It is called as the taxis. Taxis. This is process of can we see superficially that neck is strangulated? No, Harsh, don't worry. I'm coming to that point because this point is so important. That's why deliberately I have not touched it. But yes, we'll talk about it, right? Because just the answer of this question is that if we try to do that, we might lose the patient. Patient might lose his life, right? So that's why we'll talk about it and in detail about it. Just 5 minutes. Okay, so taxis is the process of manual reduction, right? So when you reduce the hernia, now you know that what is reduction, right? When you push the contents back into the abdomen, so it is called as the manual reduction. Its technical name is taxis. Few important instruction: never ever force. Never force in cases of obstructed or strangulated hernia. In these two cases, right, never ever try to force it, right? So this is extremely vital. Now when you take history, right, when you take history, patient will be giving you a very classical history that initially all hernias, right, they are reducible. So he'll say that okay, there was the bulge in the scrotum and or in the abdomen, and initially it was reducible, and then patient will say that since when it's there, so from that you will be able to say judge whether this is acute or it is chronic. And then when you ask in detail about that, are you suffering from any other disease, that is chronic coughing or obesity or lifting weights, right? So that is where you will know about all those associated conditions, right? So if the patient looks like very weak, chronic coughing, etc., so that could be one of the cause. If you find that patient is powerful but still the lower abs are weak, so many things can be associated with it, lifting of the weight, etc., right? Okay, so this is where the history part is so important. Yeah, so this is incarcerated hernia. This is not reducible, right? In this case, why there is no cuff impulse? You remember we talked about that in such cases there is no cuff impulse. There is no cuff impulse because relatively there is no relative movement, right? This area beyond the neck is is fixed, right? So that whatever the abdominal contents they are over there, they try to push, but this area, no, it won't move, right? So that's why there is no, that is tax deduction. Some of the statements of yours I actually write down in a separate book, right? This is especially that smiley one of that sacrum. This is also good, tax deduction. I will say tax reduction, you know. Acute and chronic. Okay, sorry, I should have told you. Okay, Acute means which has occurred suddenly, right? So this is good, yeah. You keep on asking because at times it happens that I take it for granted, but you are right. And chronic is something which is long standing, long standing. Say for example, if someone is having tuberculosis, constantly coughing, so it's a long history. Because of that constant coughing, there is increased intra-abdominal pressure, and because the patient is weak, muscles are weak, so that's why abdominal contents they are trying to push out, and he develops hernia, right? Okay, so back to this, there is no cough impulse because relative, no relative movement, right? No relative movement of obviously the intestinal content which has tried to come out. And we know that incarcerated means it is obstructed, right? It is obstructed. That means it is not going back, not reducible or irreducible. Say it looks bizarre, right? And then there are so many areas where the hernias they can occur, right? Of various size, various shapes, right? This is strangulated, right? And we said that strangulated is when the blood supply is compromised. That's our most important thing, that the blood supply is compromised, right? When we say compromised, that means affected, right? Blood supply is affected. So this is compromised is another word. In simple words, blood supply is is stopped, right? So that would lead to this area will can go to necrosis, tissue damage, right? Tissue damage can occur. Tissue damage. Okay. See how the patient can present, right? Patient presentation. One, bulge, no doubt about it, right? Second, because of the involvement of GIT, there would be nausea, vomiting. These are very common. And then there would be obstruction, right? Patient would be complaining of pain, constipation, because that loop which has gone out, right, and created a neck, yes, that will lead to constipation because which area is involved, that matters a lot, right? So why should it really occur, right? The major causes are one, improper lifting of weight, right? So heavy weights, but improper lifting. Say being medico, as I said that yes, will be and definitely will be doing it. We'll be conducting a session on kettlebell, heavy kettlebells. But it is at that point I definitely I'll mention. But when you lift that kettlebell, it is not so that we'll be lifting it without without any responsibility, right? Your body is vital. Your body is most important. So the way Arnold Schwarzenegger said in his that pumping iron in his book, that is when you are exercising, close your eyes, focus on which muscle are you working, right? Focus on that muscle and then start working. We'll be following that principle very strictly because immediately you will start getting the result. So in kettlebell, when such heavy kettlebells they are lifted, so actually you have to make your back very strong, right? Because it is the entire lift would be with that back. That back, if it is powerful, male and female, yes, we'll talk about this. Some of the Hernias, they are common in male. Some of the hernias, they are common in female. We'll come to this. We'll come to this. Okay. So what I was talking about, yeah. So then it comes to core muscles, and if the core are weak, the entire brunt, the entire injury that occurs to anterior abdominal wall. This is the reason that your back should be super strong. Your core should be very strong. Then you can actually build your entire body tremendously powerfully. But otherwise, say there is no fun, right? If any of such wrong things they happen, right? Second thing, second cause, as we said, chronic cough, right? Chronic cough or chronic sneezing, any of those areas which leads to raised intra-abdominal pressure, right? Raised intra-abdominal pressure. Say if someone is allergic, so then there is like constant sneezing, cough. So we talked about. That's the reason that why smoking is so dangerous. Because smoking can lead to chronic cough, and that can lead to this hernia, right? Obviously, unfortunately, someone is having any of the collagen disease. So in that case, the tissues are compromised, and that can lead to all those complications, right? And the third and most important, obesity. Gentlemen, if you are obese, right, you are all intelligent. You know that yes, my weight is more. If it is, there are so many methods to cut down the weight, right? But this obesity, motapa, right, that is a killer. Because in obesity, commonest is, as we were talking about, back becomes weak. Back becomes weak. If the back is weak, then core becomes weak, right? Because if you tell an obese person to do the plank, he won't be able to sustain even for half a minute, right? Because it is your core which is lifting the whole body, right? And that leads to when the anterior abdominal wall is insulted, this is affected. When this anterior abdominal wall is affected, gone. All these things would start, right? So, and see, being medico, when you know so much, right, there cannot be any reason not to be fit, right? And it is true that, say, human body in your age, what I mean to say, between 20 to 25, it is in its most finest stage. It is in the best stage, right? When the energy level is so high. So it is like an investment. It is like an investment, right? You take care of your body at this age, and you will get the results when you'll be 50 plus. You'll be surprised at your fitness, right? So it is like a very good investment, the best investment. Okay. All right. So now this is basically anything that increases Valsalva and intra-abdominal pressure is a risk to develop hernia. Well, intra-abdominal pressure to make sense. What is this Valsalva? Right? This Valsalva, seniors would be knowing it very well, but Valsalva is a maneuver. Maneuver means it's a method, right? It is Valsalva maneuver. Valsalva maneuver means, say, close your nose and then try to exhale. So normally, see, breathe in, right? This is forceful exhalation. But when you close your mouth, close your nose, and then try to exhale, so that will lead to increased intra-abdominal pressure, right? Valsalva maneuver itself is a big topic because there are so many things it affects. It can be used even to lower the heart rate, but again, as we don't want to deviate, that's why just Valsalva maneuver is what? Forceful attempted. You try to attempt exhalation, right? Exhalation, right? But it is not normal exhalation with nose and mouth closed, right? So nose and mouth closed. So the moment you try to do this, immediately you will find that you are raising pressure in the abdomen, right? So basically hernia occurs when anything which increases valsalva or intra-abdominal pressure. Yes. Incarcerated hernias are irreducible, right? But not necessarily strangulated. This means what? That as we discussed, right? As we discussed, as we discussed that there are two types of hernia. One is obstructed, right? And second is strangulated. Strangulated. So obstructed, it cannot go back, right? So reducible, no. Blood supply, okay, right? In strangulated, reducible, no. But so much so bad that even the blood supply, even that is obstructed. So this is what it is telling. Incarcerated or the obstructed hernia. Obstructed hernia are irreducible, but not necessarily strangulated, right? This is theory. Now here comes the answer. Harsh, I was talking about this part. That when you are managing or treating, right? When you are managing, say because there is a very thin line and you have got a limited time. What if you diagnose that yes, this is an obstructed hernia, this is an incarcerated hernia, and it turns out to be strangulated? You might have diagnosed it that yes, it is obstructed, and then immediately, just within few minutes, even the blood supply starts getting affected, right? So that's the reason you just can't waste any time. Take it for granted. Treat. This is like a golden sentence. Treat every obstructed hernia, right? Treat every obstructed hernia as strangulated. As strangulated. Just take it for granted that if the hernia is obstructed, you try to reduce, not reducing, this is a medical emergency. Unless proved otherwise, right? You do ultrasound, this, that, CT scan, all those, but unless proved otherwise. Otherwise, you will always be managing this patient as a strangulated hernia, right? This is for our safety, right? Okay. Now we talk about, say, when we say hernia, right? Divide into two parts, right? There is like inguinal hernia because this is the commonest. And then there is femoral hernia. In fact, there are so many others, right? But they are relatively rare. Indirect, inguinal, it can be direct and or indirect. When we say indirect, that means it is via deep inguinal ring. That's the inguinal canal, and this is superficial inguinal ring, and that's the passage of indirect inguinal hernia. True? Direct, straight away, jabardasti, straight away those contents they are trying to go out. Forget about ring, this, that, everything. They'll try to find out where the wall is weak. Let's go out, right? So they protrude directly, right? That's why direct, right? So what should I write? Directly, right? They try to come out directly through weakness, right? So chalo, this is Good. Through weakness of the wall. Right. Now this indirect hernia, it is common in infants. In infants. When we'll be discussing the testes, at that point, development of testes, we'll see that those testes, they develop actually into abdomen. Then they descend, right? They descend, they pass through this deep inguinal ring to superficial inguinal ring all the way along with that spermatic cord, and then they finally drop into the scrotum. So that path is open. That path is open. And through that path, those piche all those intestinal contents, they also come, right? Uninvited. They also come and they lead to what's called as the indirect inguinal hernia, right? Thank you. You know, when you understand the concept, that gives me so much of pleasure. At times, so yeah, actually, I read your even old mails also. Okay. Now this is what, right? Just by look at it, right? Just by look at it, you know that yes, this is the content which is passing through. Here it is, deep inguinal ring, right? That's the deep inguinal ring, beyond doubt. Now this is what type? This is indirect, right? So this is indirect inguinal hernia. Now here comes, how will you really identify it? You already know it, right? Because now all I need to say is you just palpate entire superior iliac spine, right? Though this angle is correct, is incorrect, right? It is just because of the space I'm drawing like this. And this is pubic symphysis, and take the midpoint, and at this point just put your finger, right? And then tell the patient head on the opposite side to cuff, and you get the pulse. You know that content is trying to go into this deep inguinal ring, and this is indirect inguinal hernia, right? So this is important point, mid inguinal point. Okay. Email ID? Email ID, I'll write it over here. It is till you are mbbs@gmail.com, right? You can send mail anytime, but just a small request. At times it happens that you might have seen that at times I reply to your mails at 4 o'clock in the morning, or say just before our session. So I try to reply as early as possible, but sometimes 1 or 2 or 3 days gap it happens. In case if there is more gap, just remind me, right? Send a mail again. So I'll definitely reply. Okay, so this is indirect. This was the indirect inguinal hernia. Now let's talk about this particular hernia, right? Regarding the indirect. And we said that indirect, it goes from superficial to deep, deep to superficial via inguinal canal. It occurs in infants, right? It occurs in infants. Obviously, the contents should be pushed in the direction towards the abdomen, right? So actually, you will, when it is in scrotum, you'll try to push the contents towards superficial inguinal ring, right? From there, you know that it is now traveling through inguinal canal. That means it is going towards mid-inguinal point. Once from mid-inguinal point, when you'll push immediately, right, entire thing will be going into the abdomen, right? And at that point of time, tell the patient not to cough and breathe very normally with abdomen absolutely relaxed, right? Okay. So in the initial stage, it can occur. This is more common in male as compared to female, right? This is the reason. That's what I was telling. It is more common in males because in males, this entire path is patent due to traveling of that descent of the testis, right? And it is like mass in scrotum, right? Because that's where the contents would be landing. Could be a congenital condition, right? There are so many, and that's where when we'll be talking about the descent of testis, right? We'll be talking about it. This becomes prominent, right? This is very common. This is this bulge, right? Prominent bulge, right? And mother notices it. That this bulge becomes prominent when the baby cries, right? Technically speaking, this is like nothing but intra-abdominal, increase abdominal pressure, right? So when the baby cries, it becomes prominent. Now, see, there are some special cases, right? Some special hernias. When this is inguinal hernia, indirect inguinal. This is called as the Gibbons hernia, right? It is called as the Gibbons hernia. When two things combine, that is inguinal is one thing, right? Indirect inguinal is one thing, plus there is hydrocele. There is collection of fluid into the scrotum. Hydrocele itself is a massive topic, huge one, right? Because there can be, and plus it's surgery, it's management. How will you invert the whole capsule so that there is no future collection, etc. Right? So it's a big topic, especially in the surgery. But and yes, we'll be discussing when we'll be talking about scrotum. But hydrocele, right? Hydro, that is water, seal, it's like cavity. So that water is collected into that scrotal cavity along with inguinal hernia. So this thing is called as the Gibbons hernia, right? Gibbons hernia. No, no. If it is strangulated, right, there is no relative movement. That's where you'll get the hint that you are not getting any impulse. No pulse, no cuff, no impulse on cuffing, right? Because when the cuffing is done, that strangulation is so powerful, internal abdominal content they will go and hit, but they won't be able to pass through it. They won't be able to. We are concerned about the post, that is that sac, the contents which are into the sac, because if it is strangulated and it cannot be reduced, chances are very high, right, that say it may lead to major complication. Yeah, water is filled into, that is hydrocele. Yes, it is CELE, yeah? Hydrocele. Okay, so that is what is called as the Gibbons hernia, right? And see what a funny name it is. It is pantaloon, right? It is called as the Pantaloons hernia. And Pantaloons hernia is when some unfortunate guy has got direct as well as indirect hernia. When both are there, right? So then it is called as the Pantaloons hernia. Pantaloons hernia. Okay, this one is direct, right? See here the contents, they are not going through deep inguinal ring. Deep inguinal ring is safe, right? Nothing has happened. And here the contents they are trying to push directly, right? So this is the direct inguinal hernia, right? Direct. So in case of direct inguinal hernia, happens in adulthood due to all those reasons, right? That is the weak abdominal wall. This is the main reason. Abdominal wall is weak. And all those risk factors, right? Risk factors, that is right from the smoking to coughing, right? Improper movements, improper lifting of weights, all those things. Say when we'll be discussing head and neck, right? I'll tell you something about our atlantoaxial joint, right? Right now I'll just take a minute to say when you take your cell phone, right? You take your cell phone and then you watch it like this. Actually, on atlantoaxial joint, right? It is just one single joint and then you're putting the entire head, right? So this is a severe mechanical disadvantage and that can lead to neck pain, right? That can lead to neck pain. Similarly, why when I say that in risk factors, one thing is like say smoking, right? All those chronic coughing things, right? This is one. Second very important point is improper posture. Improper posture. As I said that if your back muscles are weak, right? Few guys or few persons they sit like this, right? Hump. So that puts unnecessary load on the spine and it makes the spine and the back muscles very weak. Then, unfortunately, if there is any trauma, right? Trauma could be accidental, right? Some accident, or trauma could be planned. Planned means surgery, right? Right? It is surgery. So when that occurs, so it means some incision is put and that incision has not healed properly. It may lead to what's called as the incisional hernia, right? Because basically prime thing is weakness, right? So wherever the abdominal wall is weak, it tries to go out. Okay. Now we'll see one concept, right? This concept will tell you for the diagnosis, right? That what type of hernia is and with precision when you really want to say. So this is anterior superior iliac spine, right? Anterior superior iliac spine. And then this is like pubic tubercle. Pubic tubercle. So obviously this would be like inguinal ligament, correct? Inguinal ligament. On top of it, when we say that this would be the pubic symphysis, so we draw one imaginary line, sorry, it has to be over here, but okay, this is pubic symphysis, and midpoint, right? You take a center of this, and this is this distance. This distance is 0.5 inch, right, from the inguinal ligament, and this is mid-inguinal point. So I'll just write MIP, mid-inguinal point, and that's the location of deep inguinal ring. Okay. Now from this point, I'll change the color. Okay, I'll change that, right? So from here, there is, so first let's draw the muscle, right? Let's draw the muscle. The big muscle, which will be over here, he can be only one, and that is rectus abdominis, right? This is rectus abdominis. Now there would be, I need more colors. Okay, there would be one vessel, right? This vessel would be inferior epigastric write properly because this is inferior epigastric artery, right? It is this. So that inferior epigastric artery, rectus abdominis, and over here on the lower side, this is the inguinal ligament. This is forming what's called as the Hazel Box Triangle, right? This portion, this one, this, right? This is Hazel Box Triangle. Is it necessary for you to remember this? Yes, 100%. You need to remember this because I'm about to add one more content to it. And that content is, let's use a black color, right? Or it's a white one. I took black. Okay, now this is okay. So this one, no, it's not looking good. This is okay, right? This content, it is medial umbilical ligament. Medial umbilical ligament. So this medial umbilical ligament is nothing but it is an obliterated umbilical artery. So when we'll be learning, say, embryology, at that point, this umbilical artery will come into picture, right? Later on, it gets obliterated and its remnants are over there, and that is the medial umbilical ligament. Okay, so I'll just write obliterated umbilical artery. Umbilical artery, right? Fair and good. What it will do? It is dividing this entire Hazel Box triangle into lateral and medial parts. So this is the lateral part and this is the medial part. Fair enough, right? So this is the lateral part and this is the medial part of Hazel Box triangle. So that bulge, where is it occurring? That's where this Hazel Box triangle will come into picture, right? That's where it will come into picture. So how the Hazel Box triangle is formed? Say rectus abdominis, right? The lateral border, that's the lateral border. Then over here, inferior epigastric artery on the lateral aspect and lower inguinal ligament, right? Fair enough. And then it is this medial umbilical ligament which is dividing into two parts. Just in case if someone asks, right? Okay, we talked about medial umbilical ligament. So medial, there must be something like lateral umbilical ligament. Yes, definitely it is there, right? So though it is, yeah, deviating slightly, but it is okay. Lateral umbilical ligament. Just final aim is to remember everything. So this ligament, you will see that it is like a fibrous band which will be going from bladder to umbilicus, right? Bladder to umbilicus. So this is like a fibrous band. And this fibrous band is indicative of something. I think if you'll see our I don't know in the past film whether it was there or not. I'm not very sure. But this lower umbilical ligament is formed by obliterated, right? It is formed by obliterated internal iliac artery, right? Obviously in fetus. So these are like, but our focus is this Hazel Box triangle over here. That's our focus, Hazel Box triangle. Okay, and here it is. See how easy it becomes to diagnose, right? Clinically, when we try to diagnose, so we say that it is the deep ring occlusion test clinically, right? So when we say that for diagnosis, it is called as the deep ring occlusion test. You try to press it and then you feel the pulse, right? It gives. Pubic tubercle, it is easy to identify, right? You will see the tubercle, pubic tubercle, right? And indirect is medial to it. And see the femoral hernia, it is going through what? Femoral canal, right? You remember when we talked about that was the lacunar ligament, right? Lacunar ligament, and then there was a femoral canal. That potential weakness, this femoral canal, right? That was the femoral canal, yeah? And that through that potential weakness, when structures they come out, it is femoral hernia, and this femoral hernia is common in females, right? It's common in females. The direct hernia, right? And I think for that we need to go back to our this image. Yeah, this would be much better. Hazel Box triangle, right? That is the area where the direct would come. Direct to this triangle. So direct hernias, they will be coming over here. Indirect, obviously they'll be coming over here because that's where the deep inguinal ring is there. So this is indirect, right? And over here, just immediate to pubic tubercle, that is where the femoral hernia will appear. Femoral hernia, right? So in above figure, if we figure out that it is this area, that's where the femoral would come. So precise the things are, right? Because femoral has to come via that femoral canal because that's the potential weakness. And all these things, they can be diagnosed. One, that is okay, deep ring occlusion test. But the best nowadays is USG and CT scan, right? So which gives you a direct, clear visual picture for the diagnosis, and it becomes much easier, right? Okay. So when we say femoral hernia, right, we said that femoral would be via femoral canal, right, femoral canal, because it is like a potential weakness, right? But this opening is very small, right? It is quite small, and this is more common in females as compared to males. The reason that in case of elderly female, in case of elderly female, their abdominal wall has become very weak. So in case if there is malnourishment, right, malnourishment, so then also that tone is lost, right? And when it occurs, femoral hernia, if it occurs, right, so there are very high chances of, you must have guessed, strangulation. Very high chances. Obstruction, strangulation, they are very common. Reason that this femoral canal itself is very small. So in case if things are coming via it, it's bound to, say, go for that strangulation, right? All right. Now we go for a full-fledged, all at a very high pace, all the various other types of hernia. So in this case, abdominal wall hernia, those who are on the anterior side, right, they are also called as the ventral, because once again, we'll be coming to some anatomy at a later stage. So here it is like they are like epigastric hernia, right, all because of abdominal wall weakness. Umbilical, right, umbilical or paraumbilical, these are the areas from where it can occur. Spigallion, right, we talked about Spigallion hernia, right, that is intraperitoneal, which is below umbilicus, right, it is below umbilicus. Reason, you know it now very well, because the posterior wall is deficient, right? Then there could be some traumatic, right, due to some injury, some stabbing, right, or the incisional hernia. Incisional has been put, but it has not healed properly, so that is incisional hernia, right? For the posterior part, right, for the posterior, this is what is called as the lumbar. This would be your trump card. Why I am telling trump card? Because when it comes to describing the hernias which are on posterior part, there is difficulty, right? So let's draw it. Ideally, if you draw with me, it will become much more clearer, right? So this is the central axis. This is like our spine. So just schematic drawing. These are the iliac crest, right? Iliac crest, right? Then there are two lumbar triangles. So first, let's draw our favorite, right? That is lats, right? This lats looks more stylish, that's why. Otherwise, it is latissimus dorsi, right? This latissimus dorsi for those who are hearing me for the first time. Otherwise, we always call it lats, right? Look stylish. And this one is external oblique, correct? That's external oblique, external oblique. And this triangle, which is formed over here, right? That triangle, this triangle, this is called as the inferior lumbar triangle, right? This is what is called as the inferior lumbar triangle. So this is one, right? This is superficial. Now let's go deep. We remove this lats, etc., right? So let's draw it on the opposite side. So over here, that's the rib number 12. So that's rib number 12, right? Now as we are deep, so over here there would be that all those muscles which are supporting our back. So that is erector spinae, right? Then there is a big muscle, and we saw it's present even on the iliac crest also, and this is quadratus lumborum, right? Quad lumborum, right? Should I write full name, or you will know? Okay, lumborum, right? So that is quadratus lumborum, and then you have internal oblique, right? Internal oblique, and it is this triangle which is formed, right? This triangle, right? This is, see, just for our understanding, right? It is not to the proportion, right? So otherwise we might say this inferior and superior, they both are at the same level. This is just for our understanding, right? So superior lumbar triangle. When I used to learn anatomy, I used to make huge figures so that that concept becomes clear. So we could have drawn it with more detail, smaller, but when we draw such big one, right, we understand. Draw this figure 2-3 times and things will be fixed, because these are the areas, right? These are the areas where the hernia can occur on the posterior aspect, right? This is posterior. Now we go for some very special hernias, right? Just 15 more minutes, hang on, right? Are these triangles in one axis? No. They are not in one axis. One is lateral, one is medial, right? So very spatial, right? These are the very spatial hernias. I used to like those names, right? Because when you say that, okay, it is this hernia, that hernia, when you give the name, right, it looks so stylish, right? So impressive, right? So all of them, they are prone to strangulation. So that means they will be going through narrow spaces, right? One, it is Langier's hernia. Now we'll write just H. This is through that lacunar ligament, right? Lacunar ligament. That small place, right? It is trying to push through that. Then this is Narath's hernia. He is trying to go via that femoral hernia, but this femoral hernia, right? Femoral hernia, it means it will be going via femoral canal. But this femoral hernia in CDH, right? What CDH is? Congenital dislocation of hip. Now it sounds crazy, right? It sounds crazy that congenital dislocation of hip, then why it's leading to this femoral hernia? The reason is, this is interesting. This is because when the hip is displaced, you know one thing very well, that it is the psoas muscle, psoas major, which was coming all the way and it is landing on the femur. right? Just near to the hip joint. Now, when the hip is displayed, that means that psoas would be displayed. When the psoas is displayed, it will push the contents, and that's where those contents would be passing through femoral hernia. So that's where the important part is displacement, right? It is the displacement of psoas, right? Psoas brothers, major, minor, both, right? Let's write psoas brothers. Okay. Then this third one, it is called as the Seraphinis hernia, right? How interesting names. And these are the extremely rare. This is retrovascular, right? It goes behind the femoral vessels, right? So it is retrovascular. And at times I feel that this Valpian, right? He must be the friend of the Serafini, right? So they must have said that, okay, the hernia which is passing behind the vessels, you take that, and the hernia which is passing in front of the vessels, I'll take that name, right? So that way both of us will become famous. So this is like behind the vessels or in the front of the vessels. This is behind, right? This is anterior to the femoral vessels, right? No doubt they are rare. They are rare. And obviously, if they occur, yes, they lead to chances of that strangulation that is very high. Now comes the best part of our today's discussion. This is the difference. Know the difference. Know the difference. Now, in clinics, whenever you'll go, you will be examining the patient in these 4 steps only, right? That is inspection, right? Like Sherlock Holmes, first you will just watch the things. What are the findings? Inspection. Then when you touch the patient, it is called as the palpation, right? Palpation. Then third thing in which at times patient would curse you, right? It is what is called as the percussion, because patients or the non-medicos, they never understand that why that doctor, right, he's putting the finger and then doing this. Why, what are they trying to do, right? Mujhe mara kyun, right? So that is what is called as the percussion. And then patient becomes very happy when you put the stethoscope, and that is what is called as the auscultation, right? So these are the steps: inspection, palpation, percussion, and auscultation. We'll study next 2 things because they are vital in this light, right? So what are the findings in inspection, palpation, percussion, and auscultation? First is the omentocele, right? You remember what was omentocele? Omentocele is when there is no GIT, just the omentum. Omentum is herniated, right? See, so logical it is, right? And this could be one of the question even in surgery also. Omentum is herniated. So when the omentum is herniated, you just try to watch that bulge area. You will find that it is sitting silently. That means there is no peristalsis. Obviously, there won't be any peristalsis because there is no GIT, right? There are no loops. So there won't be any peristalsis. Percussion. Percussion means when this finger, right, this long finger, it is kept, and then with another long finger, you just tap, right? You tap, and then you hear something. Okay, just give me a minute, right? I'll explain in bit more detail. It will just take 2-3 minutes, but worth it. So that is first the peristalsis, no peristalsis, right? When you watch, because there are no GIT loops, right? Peristalsis, you know, right? Movement of those intestinal loops, that is what is called as the peristalsis. Yes, percussion, we are coming to that. Percussion, we are coming to that. Then when you touch, this is omentum, right? So omentum is like, it is called as the doughy feeling. Dough means actually atta, right? That roti banane wala atta. So because see there are no loops, it is just all those omentums. So those omentums, they have stuffed that entire place. So that feeling is like that doughy feeling, very soft feeling, right? And I think I would like to tell you something over here. When you try to reduce it, this is very important point. Reduction, right? You try to reduce it. Initially, it would be easy, right? Initially, it would be easy. So you will be able to push the momentum back, but the final portion, that becomes difficult. So later, right, it is not. It is not that easy. It is difficult. So if it happens like this, so now you know that we are dealing with momentum. That means as such, it is a mental piece because no GIT loops are there, right? So the chances of going into emergency, they become less. Then comes the percussion. Okay, percussion means what? Percussion is that when you try to establish, let's write it here, right? Percussion, right? This is like a music. This is like a music. You try to just say you take a dholak, right? You take a dholak and then you just play it, right? How the sound would be? It would be dum 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 dum, right? Vibratory sound, right? But then when you put your hand and then try to play, right? It won't play like that, right? It won't. It would be dull sound. So percussion is that when you put this finger and then you tap on it. Now see, this is a one sound, right? Now I put it on something else. Okay, if I put it on this, see what type of sound it is. This is metal, right? So this is a flat sound. When it comes to lungs, resonant sound, right? See, there are 5 types. Now this we are going pure clinical, right? But it's okay. But it's okay. So percussion, one is what is called as the tympanic. I always say tympanic is literally like a drum, right? Dum 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 dum, right? Vibratory. It is like drum-like sound, right? Drum-like. So it is loud, high pitch, and classically over abdomen, right? Over abdomen. Then second would be say hyper resonant. Hyper resonant. This hyper resonant, it always occurs whenever there is air. You need air, right? Then it would be resonance. Resonance is that vibration, right? And you'll get those vibrations coming back, right? So this is like in overinflated lungs. Actually, I tell you, unless and until you do this, it is so difficult to explain it theoretically, right? So okay, I'll write it in a way that you can experiment it on yourself, right? Except the emphysema, right? This is a pathological condition, and I don't really want that anyone should suffer from emphysema. According to the free cavity inside, very right, very right. Yes, you are right, right? So when it is resonant, right, you try to do this thing even on yourself, right? This is over normal lungs. Say when we talk about say auscultation, that is when you use the stethoscope, right? You need to hear again and again and again and again that okay, this is first sound, second sound, first sound, second sound, right? This is systole, this is diastole. So slowly and gradually, it is like your brain would start training itself and telling that yes, there is a difference. So even if there is tachycardia, you'll be able to decipher it, right? Same way, this is something which has to be done, right? So in fact, today, right, you can experiment on those things. The only disadvantage will be that there would be severe pain on this finger, because in enthusiasm you'll keep on tapping, right? To bichari, this finger will curse you. So here this is heard over liver, right? That is what is called as the dull note, right? And when what is flat note? Flat note is when the structure is rock solid, right? So that is over bones. So that is flat note. So all those things, right? All these percussions. Once you will know, once you will practice, you will know this is the difference between bones, and this is the how it looks like liver. And when from liver you go to abdomen, suddenly you will find dum dum dum, right? Such a vibratory sound. You go up into the lungs and you'll find yes, that's the difference. When there is resonance, you'll feel the vibes, vibrations, right? That is resonant. So these are the percussion, right? Okay, coming back to our topic. So over here in percussion, when we have omentocele, right? Omentocele means it was like a solid mass. We saw over here, right? Dull note is one, liver. Liver is solid mass. So over here, the entire sac is stuffed with that omentum. So this would be like what you get? Dull note. Dull note. Because solid mass. Solid mass. And on auscultation, right, when you put the stethoscope, it would be absolutely silent. Silent. No sound. At this point, I tell you about one which is called as the Litters Hernia. And what Litters Hernia was, we talked about Meckel's diverticulum. You remember that, right? It was like, say, this is umbilicus, and then this is like GIT, right? That's GIT, and then there is a protrusion, right, which is not going all the way. This is a part of that duct which was called as vitellointestinal duct, right? Vitellointestinal duct, right? So when the proximal portion is patent, so that is what is called as the Meckel's diverticulum, right? It is called as the Meckel's diverticulum. The importance of is that sometimes, very rarely, this Meckel's diverticulum, it enters into the herniated content. Very rare, right? But then it is called as the Litters Hernia, right? Litters Hernia. So that is when the Meckel's diverticulum, hernia of Meckel's diverticulum. And by the way, in case if it is appendix, right? If appendix is going, so then A for A, that is amend hernia, right? That is what is called as the amend hernia. So these are like the findings of omentocele. The difference would be, what would happen when it comes to enterocele? Enterocele. Enterocele means now we know that it is the bowel is present, right? GIT loops, right? They are present. So when they are present, we'll be having a completely different set of findings. On inspection, right, we find that there is some movement, peristalsis, right? Because it is those bowels are present. So peristalsis is present. Inspection, palpation, right? On palpation, right, there would be the feel of hollow structure, and most important, the reduction when you try to reduce it, right? Initially difficult. Initially it would be difficult because loops are there, right? You try to push to, when the correct loop comes, then and then it will start going back. Once it starts, then it is like a railroad, one follows after the another, and later it becomes easy, completely reverse as compared to that of omentocele, right? When it comes to percussion, in percussion, this is tympanic, right? Why tympanic? Because tympanic was that drum-like. Drum is hollow from inside, right? So this is like drum-like. Those GITs, they are hollow, right? They are hollow from inside. So this is like drum. If you really want to see this thing, right, you can do it on your stomach. When you are empty stomach, try to do that. You will find, right? So I'll just write it. For example, stomach, right? Try to do that. And on auscultation, auscultation, you will find vowel sounds, right? Vowel sounds you must have attempted, right? After eating, right? Just put the stethoscope and try to hear the music of your abdomen, right? You will like it. Okay. Finally, the surgical management, right? Surgical is MX management. One, what is called as the herniotomy. Herniotomy. You just identify the sac, herniated sac, right? Find out. Push the contents back. Push contents back, right? And close the sac, right? You have just closed the sac. You have just closed that bag in which the contents were there, right? But the original defect, so let's say this is deep inguinal, right? And this is superficial. So you have closed this sac, but this original defect, that remains. Defect remains. So that's why, because defect remains, right? So what would happen? Simple. Chances of recurrence. It can occur again, right? So that is recurrence. Chances of recurrence. But you know that when you are dealing with congenital inguinal hernia, right? So you do this type of thing, congenital inguinal hernia, because as the kid will grow, right, he'll start developing the strength. So this is treatment of choice in case when you are dealing with congenital inguinal hernia. Okay. The next, so this was herniotomy. Tomy means to cut. You are just cutting down the taking care of that sac. The second one, what is called as the herniorrhaphy. No, fluid is removed. Fluid is removed, right? But I tell you that fluid for for hydrocele, if the fluid is there, right? So then the entire sac is to be inverted. So that is a completely different surgery, right? We'll see that when we'll be talking about the scrotum, right? So hernio-raphy. In hernio-raphy, same as one, we identify the sac, right? And then push the contents, close the sac, plus you suture the edges of defect so that there is no recurrence. So this is better, right? But it is not good because it will increase the tension, right? It will increase the tension. So unless and until you know that this is a defect through which the contents passed and then they were getting strangulated, so in that case you say, chalo, this thing should not occur again. So thus this is a treatment of choice of strangulated one. So if there is any strangulated hernia and you are operating, so then you will suture that defect. You will say, no problem. Even if the pressure increases, no problem. We'll handle that, right? But say strangulation should not occur because that's more dangerous. True. The third one, it is what is called as the hernioplasty. So it is called as the hernioplasty. And in hernioplasty, it is same as 1 plus 2 plus you put mesh. You put mesh. Right? So these mesh they act like a support, right? So in that case, when you put a mesh, so this is absolutely tension free, because you don't have to take those edges together. Now you put a mesh, so there is no tension, right? So this is the best thing in which there is least recurrence, right? There is least recurrence, right? Clinically, this mesh, it shrinks. Yeah, it is like that Ghatia t-shirt, right? When you buy it, it is of XL size, and after 2 or 3 wash, it becomes of L or medium size, right? But this is not Ghatia. This is clinically, these meshes are good, but you should know it that clinically these mesh, they do shrink, right? And how much? Almost 50%. That's the reason, as a surgeon, when you use these mesh, you use large mesh, right? That's you use large mesh, right? That is one point. And the second point is that there has to be almost 2 inch overlap. So it means if this is the defect, so right, there has to be overlap on all the sides, so that even if it shrinks, still it is not going beyond that defect, right? It should cover that defect properly. So there should be proper overlap. These 2 points, they are worth remembering, right? Because these mesh, they do shrink. No doubt, there are many different types of mesh, right? If we say, right, the gross division between these two meshes, one is what is called as a synthetic mesh, right? They are synthetic, and second one is, say, biological mesh, right? Synthetic and biological. Now, whenever there is strangulation, infection, so that is where you'll be using biological, right? So in case of strangulated or infection, so you won't be relying on the synthetic ones, right? One of them is what is called as the alloderm, right? Alloderm, right? This is acellular human dermis. From that it is prepared, right? I just write down. It is acellular human dermis. Human dermis, right? That is biological. And for the synthetic, so there are so many available, but you won't be using, right? Not used in strangulation or infection, right? Not used in that. Otherwise, all standard, like say proline, right? Quite popular, right? Then there are like polyester, polyester. Then these are, then sometimes combination is used, right? What is called as the, say, Vipro. So in this there is Vicryl, right? It is the combination of Vicryl plus the proline, right? Proline. You use that combination. Then one very interesting is what's called as the PTTE. PTTE. This is polytetrafluoroethylene, right? This is polytetrafluoroethylene. So over there, now their shrinkage ratio, that decreases. So precisely you can use it with much efficiency, right? If you go into more detail, now these meshes are like solid mesh, right? They are like solid mesh, or those meshes, they are with net, right? So they are with net. So this is like net, right? That is like net. This is like net, right? There is space, and this is solid, means it is solid, right? Over here you'll be requiring sutures, right? Sutures, they are needed, right? Here in net, sutures are not needed. How come? Because when the tissue grows, tissue will be going through this mesh, and then it will anchor it, right? This is the interesting part about this. So no sutures needed. You just put it over there, no sutures needed, and the growing tissue would anchor. Growing tissue anchors it. anchors it, right? So it's like tissue would grow, right? They will start holding it like this, right? And in the beginning, what we were telling, that when it comes to say solid mesh, right, the weight is important. So that's where the heavy weight and the lightweight mesh comes into picture. And how do you say that? When it is more than 80 grams per square meter, so it is called as heavy, right? And when it is less than 40 grams per meter, so it is called as light. In between, it is medium, right? Oh, it's quite low. Do we have 2 minutes, right? Want to say I have did 2 times, but they happens in what we do now. Herniotomy. Well, in herniotomy, so chances of recurrence are very high. If you can just send me the mail, right? Mesh means net. It's like a thin cloth, right? It's not cloth, but it you can say that it's like a thin cloth made up of those special material, right? That is what is put. And yes, for your relative, if you can send me the more details in the mail. But if only the herniotomy is done, the chances of recurrence, they are obviously very high. In such case, should go for herniorrhaphy. Now there is last thing. This is what is called as, this is a state of the art thing. That is what is called as the laparoscopic repair. Right? This is what is called as the laparoscopic repair, and there are two types. One, what is called as the tap and tap, TEP and TAP. This TEP, right? This TEP is total extraperitoneal repair, right? It is called as the total extraperitoneal repair. So in this case, what really happens is that you are not, no, you are doing the entire thing above the peritoneum. So peritoneum is not breached or peritoneum is not broken, right? So peritoneum, will just say peritoneum is intact. Now that is very good. That is very good. But it requires skills, right? It requires special skills, but it is very good, right? That is what is called as the total extraperitoneal. Extra means outside. You are doing it outside the peritoneum. The next one, this one, is what is called as the TAP, right? So this TAP, it is trans abdominal peritoneal repair. So in this case, you are actually entering into the peritoneum, right? This is common, right? So over here, obviously the peritoneum is breached, but then it is repaired, right? So this was our heavyweight hernia, right? Oh yes, paneer wala cloth. Well, you can say that, huh? Paneer wala cloth. That's nice. Okay, so thank you so much that on weekend you came for such bit of heavy topic, right? I'm just saving it and I'll put it into our folder. All right, right? Tomorrow is Sunday. Enjoy. Do revise these topics, and we meet again on Monday, right? Thank you and bye bye and good night.